Okay, thank you. So I'd like to speak to you about the presbyopia surgery with Acrylisa multifocal lens, which is distributed by Zeiss and realized by a German company, Acrytech. First of all, I'd like to show you some small video to show the insertion, the implantation of a lens. The probably major amelioration of recent surgery are the way to get precise extraction of the lens with micro and now mini incision. The new phaco machine allows to get surgery through 2.2, 2, even 1.8 with the Stellaris. And if we use bifocal, bimanual surgery, we could be at 1.5 or less. And we are waiting for new lenses which could be introduced through 1 millimeter diameter. So this really fantastic improvement needs to have new lenses that was impossible even to think 3 or 4 years ago. So the Acrylisa lens we'll see after for the description. We have to precise the progress for the injectors. We can inject the lens through the cornea using the cornea like cartridge, and the lens we will see under the topical anesthesia is injected through 1.7 millimeters. So the fact is not to have absolutely records. The fact is to get a better security and better rapidity of recovery as we are doing phaco-refractive surgery for presbyopic patients. So as you see, the lens is introduced quite easily without any effort. And certainly, this new generation of lenses will be the next challenge, and there is a very fast evolution of this tendency. So the interest of these new multifocal lenses is indeed the control of postoperative control. We know that a lot of our patients are young, between almost 50, 60 years old, and we know in the next 10 years we could have an inversion, natural inversion of the astigmatism. So the control of the surgery is absolutely essential. The other progress we get with these lenses is the predictability, which is very comfortable for the surgeon because we can guarantee an excellent result and predictability with the optical biometry. The new efficient lenses have a high comprehensibility, as we just have seen in the video. And we have to precise and to tell that the refractive surgery of the crystalline lens is actually the only presbyopia correction method which is completely and definitely efficient. So the Acrylisa, we just have a quick look on the work of Thierry, everyone knows well, has shown the different, allows to visualize the ray of light and the system of the diffractive and refractive lenses. Historically, refractive lenses were the first, and they work well, giving always dominance for distance vision. Problem was they were depending on side pupil, and diffractive lenses have the opportunity to correct this point. The Acrylisa is very symptomatic of a new generation. LISA is an acronym which we'll decline right now. The L is just to explain that classic diffractive lenses divide the light between two focus, near and far, but the optical system take 20%. So you just have 40% for now, 40% for near, And the question is, it decreases really the contrast, and it can clinically, for the patient, be damaging. With the Acrylisa system, the dominance is always on far vision, 60% of far vision, whatever the pupil diameter, 35% for near, compared to the classic lenses. This advantages is to give more light on far focus, and so contrasts are optimized. The phenomena of halos with less light on the near focus are also decreased. The independence of through the pupil diameter, and we can see on this picture that there is not exactly a good reproduction between the pupil, the natural pupil, the center of the cornea, and always the center of the lens. And the diffractive system allows to have a problem, to have a patient that is not buried by this point. The point was also to decrease the side effects by the correction and the modification of the diffractive zone, as we see before. The lens is sphericized on this anterior face. The choice was less than 0.18 to correct the positive aberration of the cornea after surgery. The material is a new generation. It's an hydrophilic acrylic. It's very important because it's like a sponge. The fact it's an acrylic, you can compress it and inject with very thin cartridge. But the technique is polymerization of the surface. It's not a coating, and you have the advantage of this kind of lens. The lens structure is with square edge. Depending, as all the multifocal lenses, the optical system is very sensitive to capsular opacification, and we have to see that YAG capsulotomy are frequently more precoce than with other lenses. So the lens structure, the point is we have a large range of lengths because we can go from 0 to 32.8 dioptry by point of 85. The precision is good. The manufacturing precision is good because it's still to be precise at 0.2 or 0.25. We have also the possibility on toric lens, which is also a plate haptic with an excellent stability, and different studies show that the lens doesn't move, which is absolutely essential for this kind of lens. The patient selection has been soon described. Just 2 points. We have to see patients we want to live without glasses, but who have reasonable demand. It's indeed easier with ametropic patients, either hyperopic but also myopic. Near vision is excellent, and results even with strong myopia. We can have 0 or +1 with addition, so it works perfectly. And we have to be careful with emmetrop, just due to a slight possible imprecision in calcul of the power of the lens, and also possibility of small error of the manufacturing, which could theoretically reach 0.5, and the professional criteria we saw before. Another point, probably very important, is to explain before surgery the benefits, but also the potential discomfort with the side effects, and mainly that the night driving on the highway can be difficult. And usually people say they don't want to do, but it's important they are awake of it. It's important to have also quick and fast surgery, usually 1 week between the 2 eyes, and to tell them that they can have a decrease of vision and that the capsulotomy is normal and maybe precoce. Measuring of the lens is absolutely essential. We have to remember the rules, the Swain rule. mistake in 0.5 dioptry means 5 lines out, and 0.5 mistake, it's 8 lines lost on 10. So we get the quality and the result before the surgery with the calculation. For the biometries, there is no discussion today. Ultrasonic measure gave precision about 1 to 150 micron for 10 micron for the first generation of the Yolmaster or other duties we can get right now. Which formula? Usually SRKT works perfectly. The OFQ is able for the more higher patient. Haggis and Holiday are also very useful. The results. The monofocal uncorrected vision allows patient to work perfectly in usual life. But the results are better with bilateral implantation. The intermediate and depth of focus is good. Dr. Pietrini and other surgeons presented some results, and the intermediate vision was the best one till the new generation of Restore is something about. Contrast sensitivity is very interesting to see. The performance of the Acrylisa in mesopic condition is nearly the same as in photopic and very close to monofocal lenses. The quality of light show slight trouble and no severe trouble, halo glares or other trouble. So in conclusion, we could say that right now the modern cataract surgery with multifocal lenses means micro or mini incision. So it means 2.2 or less to control the post-operative surgery, to realize very precise biometry with the new devices, and to use actually diffractive multifocal lenses for their quality in efficient and precision in dim light. We have to see that new refractive lenses are coming on the market, but right now the diffractive or the hybrid like the Restore are probably the best one. And we have to check corneal astigmatism before surgery or to treat it. Astigmatism is no more a contraindication to surgery, as we can use multifocal toric lenses, or for someone we can also use bioptic and treat after surgery the residual astigmatism. Thank you.